The following podcast is part of a certified educational activity. Access the entire activity and complete the post test at peerview.com/NZQ860. Downloadable slides and practice aids are also available.
Hi, my name is Brendan Stiles. I'm thrilled to be moderating this session today, Immunotherapy as a Game Changer in Multimodal Management of Locally Advanced and Early Stages of Lung Cancer. We have a great faculty today. I'm a surgeon at Albert Einstein College of Medicine in the Montefiore Medical Center in New York, New York. I'm pleased that we have Dr. Boris Sepeshy from the University of Texas MD Anderson Cancer Center, also a thoracic surgeon, and Dr. Catherine Hsu from Columbia University Medical Center, who's a medical oncologist. So we have an ambitious agenda for today, and I think that we'll all learn a lot, hopefully from each other and hopefully from you. We're going to talk about cancer immunotherapy seminar and practicum for thoracic surgeons and the multidisciplinary team. As you all know, surgeons are increasingly becoming involved in this space as more and more drugs from the stage 4 space push into earlier stage disease, whether that's the neoadjuvant space or the adjuvant space. We're going to talk about each of those today with a particular focus on immunotherapy. We'll talk about navigating the current and emerging roles of immunotherapy in locally advanced non-small cell lung cancer, exploring the potential of neoadjuvant immunotherapy in early stage non-small cell lung cancer, and assessing the promise of adjuvant immunotherapy in early stage non-small cell lung cancer. And hopefully we'll get the panelists to give us a lot of their own summaries, reflections, and take-home points. So here we go, Cancer Immunotherapy Seminar and Practicum for Thoracic Surgeons and the Multidisciplinary Team, Navigating the Current and Emerging Roles of Immunotherapy in Locally Advanced Non-Small Cell Lung Cancer. So obviously this is something that all of us think about, talk about, debate endlessly on tumor boards, how to manage stage 3 patients, and particularly those more advanced stage 3 patients, maybe multi-station disease, bulky disease. We all know that there's patient factors that may lead us towards taking a patient down the surgery route versus the chemoradiation route. We know that there's tumor factors. I would love to start with our panelists, Boris and Kathy. And maybe Kathy, you can go first from the medical oncology perspective. When should surgeons operate and when should they not operate in stage 3 disease? What do you think about?
Thank you. Thanks for having us here today. Stage 3 is what I tell fellows is always the most complicated. In multidisciplinary tumor boards, we're always arguing about what we should do. And I think it's good that we all talk about it. I think for me, I really look to see whether it's bulky disease or multi-station disease. In general, I think I favor more of a chemo RT for a very bulky disease, but for anything single station or non-bulky disease, I'm a big proponent of neoadjuvant treatment. So that's something that I often talk to surgeons about. But again, obviously the surgeons have to feel comfortable with the patient factors. And so I think it's a good discussion for every tumor board to have.
And Boris, a lot of people throw around the term inoperable and how that relates to patients. Who defines that? Surgeons, medical oncologists, anything else that we need to think about in addition to what Kathy just talked about?
Yeah, well, thank you also for having me. It's really exciting to be here. I agree with what was said. The way I view stage 3 disease is that stage 3 is sort of a gateway to eventually stage 4 disease. And so once somebody is classified as stage 3, I sort of look at it as what can we achieve with local regional disease control, and what can we achieve in terms of decreasing the risk of distant recurrence. And some of the ideas in terms of single station or multi-station disease, now that we have these amazing drugs that are evolving and potentially controlling distant disease, perhaps that is changing. And really the opinion of a surgeon here is very important of, can I get the disease out completely and safely? So that the general guidelines would be certainly lobectomy is preferred than doing a major pneumonectomy in stage 3 disease. But lots of judgments in terms of patient factors, tumor factors, how many lymph nodes are involved. There's some controversy now about securing some of the sites with postoperative radiation based on the European trial, and perhaps radiation oncologists are not as keen to give adjuvant radiation sort of in this setting. So lots of judgment goes into this. I certainly prefer to do lobectomy. I have no problem cleaning out even multi-station mediastinal disease. and hopefully enrolling patients on trials, really trying to find out about their biomarkers of how can we control distant disease spread. So that's the way I approach it.
And I'll add one comment to say that it's not I don't think it's the medical oncologist who's saying whether or not the patient is surgically resectable. I generally leave that up to you guys.
Well, I think we all agree that this is a place where a real multidisciplinary approach makes a lot of sense. And it's probably because of slides like this that kind of make your head spin. There's lots of options for patients with stage 3, right? And there's lots of different types of stage 3 disease. And whether it's N1 disease, N2 disease, T3, T4, can we do it with a lobectomy versus pneumonectomy? It makes a big difference. But certainly, I think we all agree that we're getting better options. We're getting better options in the surgical space, but we're getting better options in the non-surgical space. We're better able to get those patients through treatment, I think, safely is the important point. We don't, when you think about data for stage 3 disease, certainly there's the Albane trial and study that suggests that there really is no difference between radiation therapy and chemotherapy versus adding a surgery arm. The overall hazard ratio for overall survival was 0.87, so not a statistically significant difference. There was a difference in progression-free survival that I think is well known, but maybe less discussed. There were some nuances in the difference of the group and complications and who got consolidation chemo. But people can make a rational argument that for stage 3 disease, chemotherapy plus radiation is the equivalent of those plus surgery. We as surgeons often think about the pneumonectomy problem, and Boris mentioned it a little bit, and certainly there was a highly discussed and often highly criticized radiation oncologist subgroup analysis of patients undergoing lobectomy versus those undergoing pneumonectomy. But it was a problem in this and in older studies with a 35% rate of pneumonectomy in this trial. Most of the perioperative deaths are in those patients, and the mortality was relatively high. I think at the centers where we all are, and at many centers across the country, this would be today an unacceptable mortality for pneumonectomy, but it's still an operation that we undertake cautiously. But this kind of data then obviously set the stage for the Pacific trial and for asking, can immunotherapy be moved into earlier stage? And it was logical to combine it with chemoradiation to see how we could do to see if we could improve upon this. And that really set up the Pacific trial, which was really a game changer, I think, in locally advanced lung cancer. And Kathy, do you want to go through the next couple slides? And
Sure.
I think surgeons now have heard about Pacific, but tell us again what we need to think about and know from this trial.
Yeah, so Pacific, huge game changer. We're talking about stage 3 patients, surgically unresectable, and they received chemo radiation upfront, and then followed by a year of durvalumab. And this has really changed our standard of care practice. So you can see here the overall survival, durvalumab's in the top blue line. And even if you just look at the 24-month OS, you can see that 66% of the durvalumab patients are still alive compared to placebo at 55.6% with a hazard ratio of 0.68, which is huge for a population of patients that's at very high risk. Yeah. So the updated 4-year OS and PFS data is, again, still shows very impressive numbers. If you look at even 4 years, the median OS is up to 47.5 months for durvalumab versus 29.1 for placebo. That hazard ratio of 0.71, it's very, very clear benefit. You can see a similar benefit with PFS.
I'll perhaps maybe give the surgical counter. So, right, we as surgeons got almost overwhelmed when Pacific came out. There were lots of people tweeting, talking, hey, you don't need surgery for this disease anymore, right? We've got systemic therapy. I think the counter to this is, well, what about local regional control? We were talking beforehand, and Boris made the great point that, yes, Pacific really has shown that we can decrease systemic recurrence. We can take a lot of the systemic issues off the board. But if you look at sites of recurrence or progression, rather, after Pacific, it's pretty notable to me that 91 out of 107 patients who had progressed had progression in the chest, in the lung, or the lymph nodes, suggesting that perhaps there's a greater role for better local therapy or for consolidated local therapy, some way to do better with the local disease. Surgeons often think that that's surgery. Boris, do you have any thoughts on this?
Yes, I think that both of us and probably many other surgeons out there have now encountered patients who actually potentially would have been resectable up front and were treated with the Pacific regimen and either did not tolerate durvalumab or did and completed it. And now they're dealing with essentially persistent or recurrent disease in the local area. And it's about a year and a half later, and then the surgeon is asked now to operate perhaps on a patient who could have undergone lobectomy, but now with the effects of chemoradiation within the hilum, it's a much higher risk procedure. So the point over here is that we really should be careful and think about these downstream effects, and perhaps not to burn bridges, but really make these decisions up front in terms of what is the best modality for local regional disease control in some of these patients. The data are exciting for sure, but operating after one year, a year and a half after chemoradiation and immunotherapy is definitely more challenging than perhaps resecting a lobe and mediastinal lymph nodes up front, and then maybe following it with other adjuvant treatment. So,
and I'd like to add, as a medical oncologist, that we really should be discussing all stage 3 cases in a multidisciplinary tumor board. And, you know, again, inoperable is not a term that a medical oncologist should define. And so it's something that, you know, we should all discuss with the surgeons ahead of time. Is this patient inoperable?
Yeah, I agree. These are just some of the most nuanced decisions that we make. So I think having all hands on deck really helps a lot. Pacific has obviously generated tons of excitement, and there's several other Pacific type trials out, as well as trials with other immunotherapy checkpoint inhibitors. And so I think the space is going to continue to be crowded. I think we'll continue to see positive trials, as my guess, and I think we may see some other drugs that we can add to that space that will even improve outcomes. But I still think that leaves us struggling with the idea, well, is radiation often the best means of local therapy? And I think if one turns and looks at neoadjuvant radiation therapy trials, one can actually get a sense with complete path response. And yes, there's some issues with ongoing cell death after radiation therapy and other things, but we know fundamentally that radiation just cannot kill all the cancer, and it's not even stereotactic ablative radiation. This is a wider field where complete path response rates are less. You see the reported rates of complete path response in all the major trials that incorporated neoadjuvant chemoradiation, and you see relatively low rates of mediastinal node clearance in 63%, 57%. Complete path response reported, I think, in some of these larger trials is only about 1 in 4 patients. So clearly there's a role for local therapy if we as surgeons can do it safely, just like there's a role for better systemic therapy. We thought it would be good to start with a case to sort of take you all through some of the thought process that we think about it from as surgeons and from how the medical oncologists think about this. And Boris, I think this is your case. You want to sort of tell us how it sets up and maybe ask some questions or suggestions for us?
So this is actually a very recent case of a patient of mine who presented with a rather small 2.5 centimeter tumor in the left lower lobe, however, with multiple positive lymph nodes. So he has N1 positive lymph nodes at level 11. He has biopsy-proven positive lymph nodes in level 7, and by PET CT scan, as you can see on that right side, the level 5 lymph node also appears to be positive. So we staged this patient as a T1, clinically as a T1, T2, but multi-station N2 disease. Now, on top of that, the patient also has coronary artery disease and had coronary bypass with Lima to LAD graft that's essentially lying a little bit stuck to the medial aspect of the left upper lobe. However, he has performance status of 0, and PFTs are good enough for a lobectomy. And again, this would be a left lower lobectomy. So what should we do in this setting? Should we treat this patient according to the Pacific regimen, enroll him on some sort of a neoadjuvant trial? Is surgery even a role in this patient, considering it's a straightforward lobectomy? The nodal dissection may be a little bit dicey. We have to make sure we avoid the Lima to LAD graft, but certainly he looks resectable to me. And this is a squamous cell carcinoma, so the mutational status doesn't play as much into this. And then what should the systemic treatment be? So I would be interested to hear what you guys think about a case like this.
Well, I think this is a great case that you could see in a lot of places being immediately stamped as medically inoperable because of the Lima to LAD multi-station N2 disease. But I like you, think a lot about, could I do it with a lobectomy? And I think I'm not as worried about the multi-station disease. What do you think, Kathy? What are the discussions like when you talk about these patients?
Yeah, no, I agree. I mean, I think on paper, patients often look scarier, and it's important. Boris just told us he has a performance status of 0. So for me, that really makes me want him to undergo surgery. If the surgeon says he thinks he can do it with a lobectomy, he thinks, he's pretty confident about it, I'm all for it.
And we'll talk about it in the next session, but you could also see the counter argument from surgeons. Hey, if I gave this patient, we've got these great neoadjuvant trials, but is that going to make it harder? I'm already worried about the lima, worried about the node dissection. Is giving neoadjuvant immunotherapy going to make this a more challenging operation? And I think that's a reasonable question to ask. We'll get into that in the next session. I think it's important to know that there's lots of options in the perioperative space, and it's almost confusing and again head spinning. And that's adjuvant therapy, Empower 010, Anvil, BR31, Pearls, the neoadjuvant space, often with an adjuvant arm of it or adjuvant continuation, Checkmate 816, LCMC3, Empower 30, Keynote 671. There's a lot of excitement right now, and many of you have probably heard Checkmate 816 was just presented at AACR, and we'll talk about that later in the discussion. And Empower 10 has been reported to be positive in the adjuvant setting. So clearly lots of moving parts. I think it's a real timely talk that we're having because it's going to be more and more, if surgeons aren't there, it's going to be forced upon us, these discussions. So good to be here now and good to be talking about it. So in this next section, we're going to talk about what we just alluded to, this idea of exploring the potential of neoadjuvant immunotherapy in early stage non-small cell lung cancer. So Boris, do you want to talk a little bit about the rationale? Why? Is there a biologic reason we should be using neoadjuvant immunotherapy?
Yes, thank you. Thank you, Brendan. So I would say there are both biological, sort of scientific, and also practical reasons of why neoadjuvant therapy perhaps is better than adjuvant. From the patient standpoint, at least when we looked at chemotherapy, it just appears that patients are able to tolerate neoadjuvant chemotherapy better than adjuvant therapy when they're recovering from surgery. Certainly, the benefit of neoadjuvant therapy when we're testing drugs, we can actually measure the response. We can measure the response either radiographically or when patients undergo surgery, then we can measure the response pathologically. And in fact, this is what majority of the trials have focused on. They focus on the concept of major pathological response or pathological complete response. There's also tremendous opportunity for scientific discovery because we could look at biopsies before, then we can give treatment, and we have the final surgical specimen after. And so there's a tremendous opportunity for translational research. As well as now with immunotherapy, we know that increasing PD-L1 expression is associated with metastatic disease spread. And therefore giving these novel drugs in a setting where the neoantigens are still present to try to induce T-cell response and perhaps induce long-term immune memory for anti-tumor surveillance, that's essentially the concept of why these drugs are perhaps given better when the tumor is still in situ rather than just treating minimal residual disease. So I would say those are probably the major concepts of why neoadjuvant therapy is so popular now.
Those are all great points. And Kathy, you probably know much better than either of us. Is it easier to give neoadjuvant therapy or adjuvant therapy? And do you have a strong preference?
Yes, definitely easier. And there are a lot of kind of retrospective studies that have looked into this, but in general, we say that patients tolerate the treatment better preoperatively, and you can get more cycles of treatment in.
So this next slide really talks about what surgeons want to know and worry about. And this was a collaborative paper that actually Boris was one of the authors, along with several other surgeons, Steve Broderick and Matt Bott, who have been involved in some of these trials. And in italics, I sort of put the questions that are really in our mind. But the first question is, which patients should we include, and do we have to include them? Ask your medical oncologist. What's the optimal duration, optimal combination, neoadjuvant therapy? Is this going to slow us down? Am I going to lose this patient to the OR? That goes along with what are the side effects that should be anticipated? Will patients make it to surgery? Are the medical oncologists going to mess this up for me and for the patient? And how should the clinical response be assessed? It's just so hard and so vague to reimage these patients. Do we know if it's helped us? Has it hurt us? And I think a lot of people and surgeons really obsess over this. What's the best surgical approach? Is fibrosis a concern? How miserable am I going to be in the operating room? Yeah, I might make it better for the patient, but is it going to be so miserable for me? That also affects perioperative complications. Are they going to be higher? Will this make our numbers look bad in the era of publicly reported outcomes? There's lots of things to consider, and we're hoping to take you through each of these questions with the panel to get a better handle on each of those questions. Boris, I'm going to ask you to maybe talk about this. I know you've thought a lot about it, and you're leading a big trial in the neoadjuvant space. We're increasingly working towards better upfront patient selection. Can you talk through that a little bit here and then go through the next several slides?
Yeah, so as we know, even from the AJCC 8 edition of staging, we know that patients, once they start reaching sort of 1B or stage 2 disease, the probability of potentially developing metastatic disease down the road start to increase. It goes up from 30 to 40, 50, down to stage 3, about 70%. So we know that surgical therapy affords a great local regional control and potential opportunity for cure, but we know we need additional treatment. Well, the field has really exploded in our biological understanding of lung cancer. It's not necessarily just squamous and adeno and large cell, but we know that, for example, adenocarcinomas now are essentially divided based on biomarkers, whether there's a EGFR mutation, KRAS mutation, ALK, ROS1, et cetera. There are multiple mutations for which we now have drugs that show benefit, as well as other biomarkers such as PD-L1, although none of these, the PD-L1 biomarker has not been sort of validated with a certain cutoff, but at least we see the trend that the higher the PD-L1 expression, the better the response to immunotherapy. So I think this is where the field eventually will go, and we need to learn about these tumors, not just by tumor size and nodal disease, but essentially what's driving the tumor. Is there a driver or target mutation, or if there isn't, is this a patient a good candidate for immunotherapy? So essentially, we know that besides surgery, we have to use additional treatment modalities to improve survival. And this is essentially, what I have talked about. At this point, we have, PD-L1 is one of the prime biomarker, and another one has been tumor mutation burden. Again, if we look back at the trial, some of these were turning out to be significant, but then perhaps not. In some of the metastatic setting, we do see some trends. There's a lot of translational research going into T-cell infiltration, but now actually people are even looking into the spatial distribution of the tumor microenvironment. We are looking into the driver mutations, but again, there are also studies looking into, for example, fecal microbiome and how fecal microbiome may be influencing the overall immune milieu. Or, for example, how perioperative antibiotics or any sort of antibiotic therapy may influence a patient's way of responding to these drugs. So a tremendous amount of translational research going on in this space.
Just for the thoracic surgeons so they can start thinking about fecal microbiome just to further complicate the issue, right?
That's true.
I think these cases illustrate, you sent 2 cases,
Yes.
They really illustrate some of the frustration. Can you
exactly. And so these are a couple of my cases here that I will present. And so as you can see, here's a patient with the right upper lobe tumor. And this was an adenocarcinoma that was really encroaching through the right upper lobe bronchus and would have required probably right upper lobe sleeve lobectomy. A patient was enrolled on immunotherapy trial, and within 3 cycles of chemoimmunotherapy, essentially developed this sort of a response where I was almost hesitant taking him to the operating room and performing an operation, because I was like, what am I going to remove? And should I even do still sleeve lobectomy based on the original tumor distribution with that little bit of an uptake in that area? This patient actually turned out to have pathological complete response. There was nothing there. And then here's another patient, sort of the same trial, similar type of a situation, rather a large tumor in the left upper lobe. Still, I thought, manageable with a lobectomy. Patient underwent likewise 3 cycles of chemoimmunotherapy without much of a response here, and subsequently underwent lobectomy with complete complete resection and disease control. But there was 99% viable tumor in the specimen. So we really need to find a way to stratify these patients. The biomarker search continues. Clearly, we can see that some of these regimens are extremely effective in some patients and perhaps not effective in others. And the better we can stratify people, the better we can select people for treatment, the better the outcomes will be.
Boris, don't leave us hanging. What happened with patient number 1? What kind of surgery did you perform?
So I did a lobectomy, and I sent it for frozen section, and I called pathologists before. I told them this is what I'm going to do. I don't want to put this guy through an unnecessary sleeve. I felt lobectomy was already a big deal, but he was actually a healthy young man, and he knew he was on trial. He knew he had to undergo an operation, but I divided the bronchus, and I was ready to do a sleeve in case there was some microscopic residual disease. And so this highlights also an importance in communication between pathologist and a surgeon in these situations.
Those are all great points. And Boris, I think your comment about knowing a priori really becomes important when you think about the broader context of the neoadjuvant space, not just immunotherapy, but the LCMC4 LEADER trial and other neoadjuvant trials. Can you just talk about this briefly, just so that the audience gets a sense?
Yeah, thank you for this opportunity. So I think that what immunotherapy has certainly revolutionized treatment of lung cancer. But what we have learned is that immunotherapy works extremely well, but mainly in patients who do not have driver mutations. And so this has been now recognized through metastatic setting, that patients who have driver mutations such as EGFR, ALK, MET, ROS1, there are multiple companies who actually developed targeted drugs to these patients. We know that these patients are less likely to respond to immunotherapy regimens. And therefore, there's an effort through LCMC4. The LEADER trial is the trial that 28 institutions sign up for, and will screen 1,000 patients for these mutations. It is anticipated that approximately 30% of adenocarcinoma or non-squamous carcinomas will harbor these mutations. Certainly EGFR, the most common, ALK, the second most common. The other ones occur in about 1 or 2% frequency. However, if any of us were the patient, or any of our family members were the patient, we would really want to know this. I think this is where the field is going, and so this effort by LCMC will lead into numerous neoadjuvant therapy trials for surgically resected patients who have these mutations. And this is the schema for the trial. So the LEADER trial will screen approximately 1,000 patients, stage 1 through 3. Clearly, these are sort of the surgically operable patients. There will be other profiling. The profiling could be done either at the institution where people work, or it could be done through foundation. And again, if the patient has a targetable mutation, they will be matched subsequently to targeted therapy trials. If they don't have a mutation, then they could continue with either their immunotherapy trials if they are open in those particular institutions, or standard of care treatment.
Those are great points, and thanks for taking us through that. It's a really important trial, and I think we'll learn a lot from it. I think we also have to remember that the adjuvant space is different now than when we first started all this stuff, right? So osimertinib got approved based on the results of the ADAURA trial for stage 2 to 3A disease. It met its primary endpoint of DFS, and even for 1B to 3A, remarkable DFS, a hazard ratio of 0.2. So we have great options for patients who we know have driver mutations or targets, in this case, EGFR. I think so. Then we'll get back to some of the surgical questions. What's the optimal duration and combination? How long will this slow me down? As I mentioned, there's just so many options out there, similar to the stage 4 space. Obviously, in the neoadjuvant space, it's a balance between time to respond versus potential for progression. There's a question of rapid progressors, particularly, I think this was more of an issue in the monotherapy arms where they weren't getting cytotoxic chemotherapy. And certainly most of the monotherapy trials reflected that by doing just 2 to 3 cycles. Maybe that's going to decrease the rates of major path response or complete path response based on the shorter duration. With chemotherapy, typically it would be 3 cycles, sometimes 2, operate 3 to 4 weeks after the final cycle. And certainly we see higher rates of MPR with the combination therapy than we do with the immunotherapy alone. We'll go through some of that data. The question is, how much does the partial response matter? And I think that's still a question in evolution. The next slide is really sort of the heart of the matter and where surgeons worry about it. What's going to happen? Are we going to lose potentially curable patients? Surgeons hate to be faced with that reality that you have a patient that we think that we could do a good operation on, give them good local regional control, but they might drop out because of something. In general, in the stage 4 space, and I'll ask Kathy to talk about this next, she knows it much better than I, certainly we see these exotic immune-related AEs, but they're relatively low and they're relatively manageable, and they're increasingly better recognized and treated now. Pneumonitis would be one of worry for surgeons in the neoadjuvant space, roughly 5% lower in some of the trials. The general dropout rate for these neoadjuvant trials that have been reported, again, not huge numbers, but a lot of good trials at good places, has generally been around 10%. And then a small number of patients may progress, particularly in the monotherapy arms potentially, leading to no potentially curative surgery rates of maybe 14 to 19%. I think some trials have done better and some worse. Kathy, do you want to talk to us a little bit about that, the adverse events that you see, the adverse events perhaps that surgeons are worried about?
Yeah. So, I mean, it's hard for me to follow up with a question like, is the oncologist going to mess this up? So here we go. But no, I mean, I think that the main point really is that the drugs are really quite tolerable. I mean, if you look at, this slide looks at LCMC3, which used monotherapy atezolizumab, and patients really tolerated quite well. If you look at treatment-related AEs, they're greater than grade 3 and up was only 6, so 6% of the patients. And if you look at grade 3 and up treatment-related AEs on the right, pneumonitis, there were 3 cases of pneumonitis, and the rest of these were really very manageable. And if we look at combining chemotherapy with immunotherapy, I'd make the same argument that, again, it's very manageable. We did a study here with neoadjuvant chemotherapy plus atezolizumab, and you can see that most of the AEs are related to the chemotherapy, where you can see neutropenia, grade 3 and grade 4 neutropenia was the highest. But that's expected with chemotherapy, and it was totally manageable. There was very little febrile neutropenia. And our patients mostly all made it to the operating room. I think 29 of 30 of our patients made it to the OR. So I do think that the patients do make it back to the surgeons and mostly ready for surgery. Pneumonitis, again, less than 5%, and it's not something that I saw frequently, even with the combination of chemotherapy. And then the rest of the immune-related AEs, a lot of them we're able to, either give thyroid replacement, or we're able to control a lot of the diarrhea with steroids and things. So your medical oncologist has to know what they're doing, but we definitely can get the patient back to you in one piece.
And I would echo that. I've just been amazed at how well these patients tolerate therapy. And even sicker patients going in, I really have not had many issues. I think you do such a good job getting them through it. Then the question is, how can we tell if it's helped or hurt? And do we need to know preoperatively, I guess? There's this idea, most of the trials were set up for radiographic restaging with CT or PET scan. Boris, do you want to talk a little bit about this? I know that you've thought about it a lot in the context of NeoStar.
Yeah, thank you again. Yes, so as I mentioned, with neoadjuvant therapy, we can measure response rate. And as I demonstrated with a couple other cases, we had one patient who actually radiographically looked like he had pathological complete response or clinical complete response, but until we resect the specimen, we don't know. And so there's hopefully still some safety here for surgeons because some of the trials, we can maybe advance the slide here, the first trial by Ford et al. Actually did not necessarily demonstrate correlation between pathological findings and the amount of viable tumor in a specimen versus what was seen radiographically. Because sometimes after immunotherapy, you have infiltration of immune cells and you still have sort of this mass, but you don't necessarily know whether the mass it consists of active tumor cells or fibrosis versus immune cells. I would point out that in NeoStar trial, we actually did see correlation between major pathological responses and radiographic responses. But I still think that we are far from being able to say with 100% certainty, perhaps in combination with circulating tumor-free DNA, we may be able to make some decisions. I know that in breast cancer, there's a strategy now that in patients who have complete clinical response radiographically, there are some people who are being observed rather than undergoing surgical therapy. I don't think we are there with lung cancer. And I certainly would like to point out that there are some other findings that can occur in patients who undergo with immunotherapy. And one of them we sort of named nodal immune flare. We have noticed in some patients who did not have any disease within the mediastinal lymph nodes that after getting immunotherapy, these lymph nodes look like basically a disease progression. But when we biopsied them or resected those patients, we actually found sort of a sarcoid-like reaction and granulomas within these lymph nodes. So people need to be vigilant about differentiating between sort of a true disease progression versus this phenomenon of nodal immune flare. And I would say that we have this manuscript under review right now, and actually the rate of this is not trivial. It's about 16% rather than just 10%. So If patients undergoing this kind of a treatment and it looks like their disease is progressing, I would certainly advocate for biopsies and confirming that before avoiding a potentially complete resection via surgery.
Yeah, I couldn't agree more. We had a couple of patients also with sarcoid-like reactions, which were proved benign at biopsy. So I think it's a really critical point to evaluate. I think next I wanted to talk a little bit about surgical approach, and this too is often discussed at meetings and talked about. What is the best approach? And the correlate to that is how miserable will I be in the operating room? How hard are these operations going to be? We talked a little bit about it in our group discussion preceding the talk, that probably we should always be using the approach that's most comfortable for the surgeon. I think too often it becomes a conversation of VATS versus thoracotomy. Both we know can be done safely now, so it probably should be surgeon dependent. I think certainly there's lots of great centers who can do these operations well and minimally invasively. In the earlier papers, there were relatively high rates of conversions that scared some people off. Some early literature even described operating after extended checkpoint inhibitors in other diseases and these horribly fibrotic types of operative fields. But I think it depends a little bit on the regimen, a little bit on the timing, but I do think that these can be done safely and effectively, minimally invasively, even with nodal disease burdens. But it remains to be determined which variables will affect operative difficulty. Certainly, hilar nodal involvement, we know that in everyday life that makes an operation harder. And then there's this idea of pneumonectomy. And proceeding with caution, I think we've known from previous literature that pneumonectomy has a higher mortality rate, but certainly in this setting of neoadjuvant immunotherapy, I think that that's something we should carefully consider about whether the patient can tolerate a pneumonectomy and whether that's the right thing in the setting of having better chemoradiation, durva type options systemically. If you look across the spectrum at most of the surgical results that have been reported, I think a couple things stand out. Number one, as I mentioned, that minimally invasive surgery can be done safely in many patients. There's different rates across the different trials that are reported, but certainly at centers who do minimally invasive surgery, many have plugged ahead with that as an approach for these patients, which I think is very appropriate. I think rates of R0 resections are as would be expected in this population, which generally has a heavy burden of disease. And I think finally, surgical complications, as we talked about, are very manageable, and we'll talk about that a little bit later. This was a small study that we did that was really meant to answer this question of hilar fibrosis, and I think we really answered it imperfectly. I think the problem really is that it's a really subjective description, and how every surgeon says, this was the hardest case. But it's not, and some have tried to develop scoring systems to score hilar fibrosis. We did here, and we tried to compare it with a historical cohort of patients who had gotten chemotherapy induction. We really didn't see a huge difference in the proportion in which we described major fibrosis in the operative reports. Notably, it was higher in the neoadjuvant immune checkpoint inhibitor cohort who had positive disease, and so maybe that plays a role. And then certainly we see sometimes cases like this, and this was one of mine where just a middle lobectomy, it was really sticky. Everything was stuck around the PA, the fissure. And anecdotally, in the early review of our series, patients who had a major path response had higher rates of fibrosis. And that may make sense if you're getting a better immune response in the nodes in particular. It might make some of the dissection a bit more tricky. Boris, what do you think? Experience and thoughts about fibrosis and scoring it? Is it subjective? Can we figure it out objectively?
Yeah, I thought about this as well. And at this point, obviously, many of the trials have rather smaller number of patients. So we try to quantify it. We try to sort of subjectively or empirically ask surgeons to grade the level of inflammation of fibrosis and try to give it some sort of a definition. We thought about potentially getting some biopsies, et cetera. I mean, at this point, it is more of an empirical experience, and I would say it's somewhat idiosyncratic. I'm not 100% sure that we have enough powered data to say whether this is associated either with the nodal immune flare response or if it's associated with the response to therapy, et cetera. I do have to say, though, that in a setting of targeted therapy as well, there is no question that there is effect on the tissue from these different drugs. And I would say that the most consistent one that I see is actually with anti-EGFR therapy or TKI inhibitors that sort of create a little bit more sticky lymph nodes right around the pulmonary artery. So I think that we just need to be vigilant, and I think surgeon dealing with this case after neoadjuvant therapy should obviously approach it with the way they would usually approach the case, but kind of test the waters and see, if I'm dissecting the vein, what is the tissue quality? I mean, these are things that's what surgery is. It's partly an art and an empirical experience is extremely important, and only surgeons kind of know what they talk about when they make an incision. And sometimes, we know what tissue feels like after steroids, for example. So this is the same concept, but I think more study needs to be done to be able to predict it going in, because CT scan doesn't show this to us, or imaging doesn't show it to us. So perhaps looking at some biomarkers that are associated with this will give us a better sense of what we're getting into.
Those are all great points, and that probably directly affects or potentially affects complication rates, right? And we all live, surgeons, in the era of publicly reported data, where we have to report our outcomes, complications, mortalities. And so surgeons often worry that that's going to look worse if we operate on patients after neoadjuvant therapy, if we operate on the most challenging patients. But I think really if you look across the board, and we'll show a couple studies, that the rates of complications are pretty similar to those seen after induction therapies. The most common are typical things: atrial fibrillation, UTIs, some pneumonias. And the length of stays have been very reasonable, about 4 to 5 days, like reported, I think pretty standard across the board for what we see after standard induction therapy. We're going to talk about 2 trials really just as examples. I think this is from that New England Journal series, the initial publication by Fordnaw, and then Matthew Bott from Memorial broke down the perioperative data. And at first glance, this may scare people because this is just 20 patients. You see that the thoracotomy rate was 70%, morbidity was 50%. But if you look underneath that, you really see that the majority is atrial arrhythmias, which are typically transient, 1 pneumonia, 1 PE, 1 MI. So the major complications here are relatively low, although if you look at the 50% rate, you may scare some people off. I think a better window is probably the study that Kathy led with neoadjuvant atezolizumab and chemotherapy, so multiple agents. But you see the group did about half as VATS, and obviously they have excellent VAT surgeons there. They did 3/4 as a lobectomy, and pneumonectomy rates around 10%, which I think has been standard for most of these trials. And you see very impressive surgical complication rates, very low rates. Length of hospital stay 4 days, 1 readmission. So really, surgeons can do these safely. I think how that translates out into the general community, into broad spread use of these regimens will be interesting. It will be something that we have to keep an eye on to make sure that that we don't start to see an increase in complication rates. But increasing in the community, I think there's a growing confidence that these cases can be done safely. So we're up to this idea, the medical oncologists are doing a great job, the surgeons are doing a great job, we're getting them all through, and then what's the end point? What is the true path response rate? And the correlate to that is, are these people misleading us? And that's meant tongue-in-cheek. Certainly they wouldn't mislead, but the 45% major pathologic response rate reported with neoadjuvant nivolumab alone in this trial published in the New England Journal was shocking to many people, and it was so high and generated so much excitement. And the question was, will that hold up in larger series as you expand it out to others? And the group saw responses in both PD-L1 positive and negative tumors across different histologic subtypes, and saw it with and without lymph node metastases. I think that sort of initial enthusiasm has been tempered as the numbers in monotherapy trials have started to come back down. Certainly we'll show some data that shows combination therapy leads to better major path response rates. And maybe we can start out talking about NeoStar. Boris, you want to talk a little bit about this and about the philosophy here?
So the NeoStar was the first randomized trial that looked at the single modality of nivolumab versus dual immunotherapy with nivolumab with ipilimumab. The trial was actually powered as a comparison of major pathological response against historical controls with chemotherapy. And what this trial demonstrated with the effectiveness based on major pathological response rate in the intention to treat population, the response rate was 22% with nivolumab alone, but it was 38% with Nivo-Ipi. And if we only look at patients who underwent resection, because there were few patients who did not undergo resection on this trial, actually the pathological complete response, which now seems to be becoming kind of maybe more consistent and more reproducible outcome in the trials in the Nivo-Ipi arm was also 38% and 10% with nivolumab alone. So this trial really demonstrated that adding another checkpoint inhibitor, this anti-CTLA inhibitor, not only improves pathological complete response, but also there was increased infiltration of memory T cells within the tumor, perhaps suggesting that the immune memory and disease control down the road would be better in this arm, but we obviously have to wait for these data to mature.
So that's a great study. Thanks for taking us through it, Boris. I think it's also important to highlight LCMC3, which was another multi-institutional study and one of the largest neoadjuvant trials reported. It's been discussed at several meetings, and Jay Lee has gone through the surgical issues extensively. This, I think, is more reflective of the pathologic response with single agent. A lot of this, though, has, I think, generated a bit more enthusiasm probably for combination therapy trials with chemotherapy and immunotherapy to try to drive that major path and complete path response. Kathy, do you want to talk a little bit about your trial and then about Nadim?
So Nadim and our trial both looked at neoadjuvant immunotherapy in combination with chemotherapy. And our trial looked at using atezolizumab in combination with carboplatin and nab-paclitaxel. And similar to what Brendan was saying, with the addition of chemotherapy, we found that the pathologic response numbers were much higher. So we had a major path response rate of about 57% and a path complete response rate of a third, which is really quite impressive when you think about neoadjuvant chemotherapy alone. The path response rates are single digit. And we also should note that in our data, more than 3/4 of the patients had stage 3 disease. So it was a pretty high risk population to start. And similarly, Nadim looked at resectable 3A disease. So they only took 3A patients, so even a higher risk group. And they looked at nivolumab plus carboplatin and paclitaxel. And the important thing also to note is that they had an adjuvant nivolumab arm as well. And their numbers were also very impressive. If you look at their major path response, 83%, and a complete path response rate, 63%. And they also had their PFS numbers, which were out, and I think at 24 months, their PFS numbers were still at 77%, which is really impressive if you think about their population of stage 3A patients. So I think overall, the chemo IO combination seems to be tolerable and really quite effective.
Yeah, that's pretty remarkable data. And as we all know, there's lots of other studies in the space. We're going to go through Checkmate 816, Keynote 671, Empower 30, Agent. There's just so much action going on and so much excitement. And it seems to me like everybody's really turning towards and focusing on these combination with chemo type trials. I think I'm going to ask Kathy to go through the next trial, which was really just presented at AACR 2021, just a week or two ago, Checkmate 816. And so forgive her, these slides are fresh and the data is fresh, and we have yet to see a publication, but this generated just tremendous excitement. And maybe Kathy can take us through it, and then Boris and I can comment as we go if anything jumps out at us.
Yeah, no, thank you. This is really exciting because these are kind of some of the first numbers we're seeing from a phase 3 trial. And so this was Checkmate 816, where they randomized patients from between chemo plus nivolumab versus chemotherapy. And so this is similar to some of the phase 2s we were just talking about, but if we want to just focus on the baseline characteristics, again, the stage 1B to 2, about 36%, and the stage 3A, 63% of these patients. And then, the other important things, I think, when we delve into the data, 21% of the patients had greater than 50% PD-L1 expression. So in terms of the patients who received treatment, you can see that most of them did receive neoadjuvant treatment in both arms. And then let's look down at patients with definitive surgery. I think this is in line with some of the other numbers we had seen before, but 83% of the patients on the combination arm underwent surgical resection, and 75% in the neoadjuvant chemotherapy arm.
Yeah, pretty interesting data. Boris, any thoughts? I think the pneumonectomy rate may be a little bit higher. We had discussed a little bit this idea of patients making it to R0 resection, whether that reflects heavy disease burden in some of these patients. I think this is sort of our first look at phase 3 data. Any other thoughts?
Yeah, I mean, I have to commend 816 and all the investigators in this trial to bring this multi-institutional difficult trial together. I mean, obviously, we would like to take 100% of patients to the operating room. They all should be resectable, and our goal should always be to achieve 100% R0 resection. So perhaps these data really represent what the true situation is out there, and perhaps there was maybe a little bit more excitement thinking that some of these patients would get downstage, etc. I think we'll have to wait for the final report and see what the investigators how they will comment about some of these data. The chemotherapy arm as compared to, let's say, S9900 trial, the SWOG trial, I think that will be compared as well. But I certainly commend the investigators for completing the trial. And we will probably learn more about these R0 resection rate as well as the overall resection rate.
Exactly. And that point you made about patient selection, I think, remains extremely important. We're finding that these treatment regimens are manageable, they're tolerable, but patient selection is still one of the most important things.
Great points. Kathy, you want to take us through the punchline?
Yeah, and then this is really, the punchline here, that the path CR rate went from 2.2% with chemo alone to 24% with the combination. I think the odds ratio was like 14. So that was really impressive. And, notably the central pathologists were blinded to trial arms. I think that's really the takeaway here, that we saw a clear difference in the pathologic response.
Pretty remarkable. And you see, even in those curves, even the patients that didn't have major path or complete path response, there were a lot more responses than with the chemotherapy alone. I was pretty impressed with that data.
Yep.
Any thoughts on different subgroups, Kathy?
Yeah, I mean, again, we're all, for every treatment type we're giving, we want to know how to select patients. I think that the PD-L1 score, it's interesting. There's no real, we didn't see any significant difference. And I guess that's the same thing that we've been seeing with some of our other combination phase 2 trials, that PD-L1, patients with PD-L1 negative tumors can still respond.
Yeah, pretty remarkable.
So overall, we're still waiting for EFS endpoint to mature. I think that that's still important for us. We think that pathologic complete response correlates to survival, but we have to show that. But again, echoing Boris, commending these investigators for finishing this study, showing that surgery was still feasible, treatment was tolerable, and we did see, and they had an exploratory subset analysis where they looked at ctDNA clearance, and it was met more frequently with the Nivo plus chemo arm. So look forward to seeing more of their results.
I thought that data was pretty impressive, and I think that gets to what you and Boris talk about, this idea that we should be able to figure these things out better through molecular markers or ctDNA, rather than just guessing. We're increasingly moving into an area where we know more about the patients and about their tumor and about their disease status. So I think that's an important endpoint as well. I think so. To sort of wrap this part up, I think hopefully we've convinced you that surgical resection after neoadjuvant immune checkpoint inhibitors can be accomplished safely, often minimally invasively if that's the surgeon's preference, and with relatively low rates of dropout. Fibrosis is a concern, and it may be encountered, but it's often encountered in these patients anyway. We know that they have a heavy disease burden, and it really has not been detrimental, at least in the early studies, to outcomes. When operating early after neoadjuvant immune checkpoint inhibitors, I think technical challenges and complications aren't significantly different than when operating after neoadjuvant chemotherapy, at least in my experience. MPR rates after neoadjuvant immune checkpoint inhibitors are likely in the 10 to 20% range for single agent, but with the addition of chemotherapy, obviously there's a lot of excitement. We're pushing these major path response rates, even complete path response rates, up near 50% in some cases. And that obviously has lots in the field excited. It should have our patients excited. Surgeons can and should be willing partners in these trials, both in thinking about which patients to enroll and in getting the patients through safely. And I think that's a good time to kind of move to another case and talk about this one. Certainly looks daunting at first glance. Boris, is this another case of yours, or is this?
I think this one was mine. This was actually a patient on our neoadjuvant chemo trial. This was a young man who had squamous cell carcinoma. He had a positive subcarinal R4. very central tumor. We had discussed him at tumor board, and the surgeon thought he might need a pneumonectomy. We decided to put him on trial still to give him, the best possible treatment he could get for a 50-year-old guy, and he had a really nice response.
What do you think? What do you think, Boris? Just looking
what do you
at
think?
that case ahead of time. I'll go back to it.
I'm looking at this picture over here, and I'm concerned by some of the compression of that SVC. I think that's the azygos coming into the SVC, and you can see how it's all shifted towards the mediastinum over there. I mean, certainly brave case. I think doable, but I think that's a sort of a brave enrollment on the trial. But squamous cell histology tends to respond a little bit better to these regimens, and so I think that was a reasonable calculated risk. And I actually agree that given this patient, neoadjuvant chemoimmunotherapy probably the best choice. Imagine trying to operate after, let's say, definitive chemoradiation here. So I think challenging case. I would be a little bit worried about the SVC and be ready to do something with that. But the lung and the bronchus and the risk of pneumonectomy, especially on the right side, is high as well. So tremendous judgment here.
Yeah, I think great points too. And I think one thing we learned, everybody in their smaller trials where we were just trying to accrue patients into, we sometimes put some patients in with relatively advanced disease. And I was pretty impressed that we got pretty good outcomes with some of those. I think, again, I commend Kathy, you and your group for taking this on. So what happened there?
So he did very nicely. He got all 4 cycles of treatment, and he ended up undergoing a bilobectomy. So he had a muscle-sparing thoracotomy, sleeve resection, and bilobectomy in the end, and has done really nicely. His pathology ended up being 90% necrosis, so he met a major path response. The N2 nodes were all cleared, and he's still doing well. So I think I agree with Boris. It was a tricky case that we were discussing whether or not to put on, and hindsight is 2020. We're glad we put him on, but he definitely did very well with it.
Yeah, it's always interesting. I always think it's important to keep in mind that this would be a pretty big radiation field as well.
Yeah.
Maybe with not as much toxicity up front, but potential toxicity down the road as we're sort of starting to learn more about and think more about. I certainly think that there's cases that are perfectly appropriate and should be treated with chemoradiation, but I also think this allows us to sometimes think about being more aggressive surgically. So we focused a ton on the discussion about neoadjuvant immunotherapy trials, and actually there's a lot of excitement in the space. These are certainly trials that surgeons should and can be heavily involved in. But it's also important to point out that there's a lot happening in the adjuvant space. Obviously, surgeons may have less of a role here. We've resected the patient, they've moved on to the medical oncologist in some cases. But I think it's important for us to think about and to sort of be aware of what's happening in the space. Based on a similar idea, significant activity for these drugs in stage 3 and 4 disease. Maybe immunotherapy is more effective in the setting of minimal disease burden. Immunological pathways are disrupted by surgical stress. Maybe that provides an opportunity to come in with an immune checkpoint inhibitor. And then probably some of the things the surgeons like, hey, there's no risk in delaying the surgery if we go with an adjuvant approach. Maybe it's harder if you give neoadjuvant therapy. It's certainly not hard on the surgeon to give adjuvant therapy. And again, there's a proven benefit to adjuvant chemotherapy. We know that adjuvant therapy can improve survival. So if we take our better drugs from the stage 4 space and put them in the adjuvant space, it would seem to make sense. And obviously increased response rates, efficacy, and manageable toxicity profiles with these drugs that are well established in the stage 4 space. So increasingly, we're seeing some trials set up to use immune checkpoint inhibitors as maintenance following standard of care cytotoxic chemotherapy. And sort of thinking about that, I think, is important for surgeons too, as you consider whether to put your patient on a neoadjuvant trial, whether to operate up front, how you're going to stage the patient, the conversations that you have with the patient about adjuvant therapy. Multiple ongoing trials that are all listed here. I won't go through them, but each will start to report out, and we'll see more and more news about these, how they sort of jockey with the neoadjuvant trials and sort of jockey for patients compared to the neoadjuvant trials, I think will be interesting, but I think it'll be a big place for surgeons to make an impact in. And probably most notably is the EMPOWER-10, the phase 3 study. There's a press release that said it met its primary endpoint of disease-free survival at the interim analysis. It still hasn't been reported yet, but is likely to be at one of the upcoming meetings. This was atezolizumab versus standard of care in the adjuvant setting, again, after standard of care adjuvant chemotherapy. And the release said that atezolizumab showed a statistically significant improvement in DFS as adjuvant therapy following surgery and chemotherapy in all the randomized stage 2 and 3A populations in the trial. And the magnitude of benefit was particularly pronounced in the PD-L1 positive population. So we're happy to see that we've gotten some questions from the audience, and I wanted to take a quick look and answer some of these. A couple jumped out at me, and I think one is still something I try to wrap my head around. What if you get significant what if you get significant inflammation or you see specific immune-related adverse events in the neoadjuvant period? Should there be an interval before surgery to allow for those things to settle out, and how would you treat those? Kathy, what are your thoughts on that?
Yeah, I mean, this definitely can happen. And we had a couple patients who did develop some IRAEs. Generally you stop the treatment. You give a course of steroids. It could be a short course. I mean, some of these things like colitis can respond very quickly to a short course of steroids. We did take 1 or 2 patients to the OR early. One patient had issues with immune-related thrombocytopenia and neutropenia, and we stopped treatment, took them to surgery early, and they still met a major path response. So I think it's okay to stop the treatment, but treat the IRAE usually with steroids, and then when the patient's inflammation calms down, take them to the OR then.
Yeah, and I agree completely. I think it's not like the stage 4 space where there's disease and these patients seem like they'll do anything to stay on treatment. I think in the neoadjuvant space, it's perfectly fine to stop.
Exactly.
And we had one patient with pancreatitis after just 1 dose of durvalumab. I mean, we just gave them the 1 dose and took them to the operating room a couple weeks later, and they had a major path response. I was amazed by that. Boris, Do you have any experience or any thoughts on that?
Yes, I agree. I mean, as surgeons, as soon as we see patients with lung cancer that is resectable, the idea is, well, take him to the operating room before the disease spreads. But we know that the biology of lung cancer is not such that probability, the doubling time of lung cancer ranges between 100 and 400 days. And especially if patients actually receive at least 1 cycle, they seem to be protected, I think, from those drugs. I think that in these situations, we just need to follow clinical picture of the patient, let them recover so the surgery could be done safely. I certainly would not advocate to taking someone early to the operating room if they're not prepared for it, just for the thought that maybe we will prevent eventual disease spread. So really having clinically stable patient and ready for the operation is the best thing.
Totally agree. Then another question came in. We talked about this a little bit, but it's always worth coming back to. Can you address the concerns related to fibrosis and conversion rates with immunotherapy use versus induction chemotherapy? Yeah. Boris, you had talked about that a little bit. You want to expand upon that?
Yeah, so I'm going to use then the data that we tried to put together on this quote-unquote surgical complexity in NeoStar. We have 8 surgeons, 9 surgeons here at MD Anderson who have operated on these patients. And so we have tried to quantify this data or give some kind of a number to the empirical evidence of the surgeons and essentially prospectively ask the surgeons to rate the difficulty of the operation. We created a 4-level scale where we basically assign number 2 to what would be a normal anatomical lobectomy for stage 1 lung cancer without any treatment. So I want to make sure that people understand that we scaled it to what essentially removing a normal anatomical lobe would be. So it wasn't stage dependent or stage stratified. And I also would like to say that vast majority of the patients in NeoStar trial had earlier stage disease. So overall, surgeons felt that maybe 40% of the operations are perhaps a little bit more difficult than that number 2, than a normal lobectomy. Now, it correlated with the operative time. And it operated and a little bit with perioperative blood loss, although the perioperative blood loss was not high. So clearly, if the surgeon was in the operating room longer, they felt that there was a more complicated case. Again, these data are sort of not validated, not subjective. We could not find any clear correlation with any pathological response. But as you mentioned, Brandon, we encounter difficult cases even with upfront operations when we see sort of a little bulky lymph node or if there's a gross lymph node positivity on imaging, we know that the removal of the lymph node may be difficult. We can't really predict extranodal lymph node invasion versus just a microscopic lymph node disease. So again, I think that thoracic surgeons should really be well versed in all techniques. I mean, minimally invasive technique could be start. Low threshold, if I feel like there could be some bleeding, get maybe proximal PA control, maybe call a colleague in, etc. Converting to an open operation, certainly there is no harm in that. We know that we can get patients through. We use EXPAREL and enhanced recovery pathways. I think these operations could be done safely, and any STS-related objective measures do not suggest that outcomes are any different than either operating up front or after chemotherapy.
That's a great summary, Boris. Thanks a lot. You can see in the questions, there's also a lot of interest about Checkmate 816, and it's probably tougher for us to answer given that it's just based on one presentation just a couple of weeks ago, and we're all still trying to learn and wrap our heads around the data. But maybe I'll put it another way. What are you most interested in seeing from that study, or how do you think it affects your thinking? Kathy, you want to take that one on?
Yeah, I think what I'm most interested in is knowing about that adjuvant time afterwards and whether or not we think that that's important. So the trials are all designed a little differently. I think Empower 030 has an adjuvant arm, Checkmate 816 did not. So, I'm just kind of curious to see whether or not that will be important and whether or not we think that patients will need that extra year.
How about you, Boris? Any thoughts?
So what I really like about this trial is that the concept of major pathological response switching into pathological complete response. The reason we have used the MPR is because chemotherapy had such a low path CR rate. And it was very difficult to power the studies based on PCR. Now that we can achieve higher PCR rate, I think that it is a much better endpoint. Now we will have to wait to see whether the association with PCR also translates to better overall survival. But once we reach that, I think that all future trials will have this potential surrogate biomarker for better long-term outcome. So I like that switch. And I agree that I think we'll have to take a look at subgroups and responses. And I still believe that the field has already kind of gone past this. That with the LCMC4 efforts, we now know that we really need to screen patients up front, not only for EGFR ALK, but all the other mutations. And so perhaps if we really stratify all these patients by all the driver mutations and all the other potential treatments they could have been on, the results with chemoimmunotherapy in properly selected patients could be even much more significant than what we're seeing right now. And I think that's where the field is going.
Yeah, I think those are all incredible points that both of you made. And I'm also pretty excited about the ctDNA and really understanding how that's going to correlate with event-free survival down the road. I think, again, more information, right? It'll help us plan out adjuvant therapy, the duration of adjuvant therapy.
Exactly right.
So I think there's an incredible, rich data set within that trial that we'll look forward to hearing more presentations on. I want to return to one comment. Actually, as we sort of get to the final part, we can maybe talk about this. But the point that Boris made, I think, is a really important one. And actually, the group at MD Anderson has written a lot about it. The idea of return to intended oncologic therapy. So making sure that we as surgeons, it's not just surgery now. We have so many tools available and so many great options. It's our job to make sure that the patients get to that therapy, and whether that's upfront, whether that's after. That's really predicated on safe operations, sometimes minimally invasive operations, getting them back to performance status 0 as soon as we can. And I do think there's an increasing role for surgeons to be aware of that and to really, it falls upon us to do that for our patients. I think, the other things that you heard, and I'll ask both Boris and Kathy to summarize and to sort of to talk about, reflect on what we talk about, but I'm amazed at just the space and how much it really has become a space where we have to know everything about the patient as we consider these different options for the patient, just like stage 4, right? We wouldn't treat any of these patients without knowing their molecular status, without knowing their PD-L1. I increasingly believe that that's important in the early stage space. It's been a great panel. I'd love to hear, Kathy, I'll ask you to go first. Do you want to give some closing thoughts or reflections?
Yeah, I feel so fortunate to be practicing medicine in this time and day where we are seeing the amazing responses that we're seeing from, immunotherapy to targeted therapy. And I love that we're bringing it from stage 4 to stage 3 and stage 2 and stage 1. And just to the surgeons out there, I love that we're having this really increased collaboration. When I did my neoadjuvant trial, I went back into the OR for the first time in 15 years. And I got yelled at by the scrub nurse once or twice, but it was so nice to see, and I really love working with the surgeons, and I hope you guys feel the same way.
Yeah, absolutely. Boris, you want to give some closing thoughts?
Yeah, I absolutely agree. I mean, I think we all go into surgery because we like the technical aspects. We also like the immediate satisfaction of, removing someone's tumor and treating the disease in such an aggressive way. But we also, I think, need to recognize that there is limitation to just the local disease control, and that the biology of the disease truly determines how the patient does in the future. And I think that this tremendous collaboration we have with our medical oncology colleagues, learning about the biology, sequencing of therapy, sequencing of tumors, and more so, as you mentioned, Brendan, the patient's quality of life and how they're going to tolerate the therapy. I mean, we are in the era of patient reporting outcomes, et cetera. I think all of these things are very important, and I like the complexity of it, and trying to push the field forward through this multi-modality therapy.
Yeah, great points, and a great way to think about closing. So Boris and Kathy, thanks for all your thoughts and insight. You've both been incredible leaders in the field, and so I think we're privileged to hear your thoughts on this matter.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/NZQ860. This activity is supported through independent educational grants from AstraZeneca, Bristol Myers Squibb, and Genentech. This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.